Thank you, and I'm very pleased to be with you all today to share a model that's been near and dear to my heart of a collaborative model for building barrier-free mental health and wellness program for medical staff and trainees. As was mentioned, my name is Dr. Rob McGregor. I'm a professor of pediatrics at NeoMed, and most of my hours are spent as the chief medical officer overseeing many activities, but wellness is really high on my list. When I do clinical medicine, I'm a pediatric hospitalist. I have no disclosures of a financial relationship, but I am pretty invested in this program since I feel like it's my baby. Okay, I want you to consider the case of Dr. K. As a seasoned orthopedic surgeon and former department chair, I always thought I was bulletproof. In my mind, there was no stressor related to my career that I could not manage. Unfortunately, like many of my fellow providers, I was trained in an environment where it was unacceptable for a doctor to struggle with any challenge related to his career. I was explicitly and implicitly told to suck it up, suffer in silence. Hence, like many of my colleagues, as I continue to learn, I developed some less than functional coping mechanisms which enabled me to bottle up my feelings of despair, compartmentalize them, so to speak, especially those that occurred when my patient outcome did not meet my self-imposed degree of perfection. Several months ago, following a procedure, I had a patient complication. My mechanisms used in the past failed me. Even peer discussions failed me. I was spiraling. I placed all the blame on myself and felt that I needed to make dramatic changes in my job to ensure this could never happen again. I was considering limiting my surgical practice to avoid that particular problem, which had always been my favorite. In fact, I got referrals for this all the time. I would transform my practice to become a non-operative orthopedic provider or even consider early retirement. I had never even remotely considered seeking mental health services. In case you think Dr. K is alone, I'm going to just flash through some titles. Since this audience is pretty informed already, I'm not going to go through the narratives of each of these articles, but the titles are telling. The Painful Truth, Physicians Are Not Invincible. This was an article written by a psychiatrist who lost 3 peers in the course of a year to suicide. Medicine's Shame Problem. Professional Stigma of Mental Health Issues. Physicians are both the cause and the solution. And this really talks about the balance between perfectionism and reality. This alliteration, perfection, power, and process, what we must address to dismantle mental health stigma in medical education. And normalizing disclosure, or are we reinforcing heroism, an exploratory critical discourse analysis on mental health stigma in medical education. So this topic should tell us that Dr. K is not alone. This article, though, I think is worth point out to you. Dr. Kirsch is a psychiatrist who was the dean of 2 medical colleges, University of Georgia and my own alma mater, Penn State University. He was a dean for about 15 years before he became the CEO of the AAMC. And now, after retirement, he's sharing his adverse childhood events and some graphic trauma he experienced early as a first responder, and which created flashbacks as he would do anatomy lab, and he almost dropped out of medical school. I think this is an important personal reflection that's should be a message to all of us that the more we hide it, the more we're reinforcing the fact that it should have stigma. So I encourage you to take a look at this in academic medicine. The learning objectives for today is to make sure we're all on the same page and define some basic elements, burnout syndrome, and discuss the impact. List the barriers that get in the way of us getting mental health treatment. Described the concept of opt-out counseling, how we've incorporated that into our program. Then described the larger progress of the Akron Physician Wellness Initiative and paid special attention to why a 501c3 status might add value as you're building some of these programs. Burnout syndrome. Burnout syndrome is actually an ICD-10 code now. It's characterized by emotional exhaustion, depersonalization, cynicism or detachment. And that's where we kind of take our patients and put them into the problem or the headache or the appendix in room 4, and then loss of a sense of personal accomplishment. My psychiatric colleagues are quick to point out that this is really an occupational specific disease. So it's emotional depletion, feeling frustrated, tired of going to work, hard to deal with others at work, detachment, being less empathetic with patients and other colleagues, and as I mentioned before, seeing the patients as diagnoses, and low personal achievement. I'm experiencing work as unrewarding. I'm going through the motions, and it's depersonalized. It's as if I'm watching myself from a distance. It's not real. I don't belong to myself. I find it very helpful when I look at the issues related to physician wellness, whether it's burnout, depression, any other elements, to look at it with this paradigm that came from this article in the New England Journal of Medicine Catalyst. And I've seen Tate Chanefeld use this over and over again. He was one of the developers of this model. And it basically puts at the center professional fulfillment. And that's our goal, is we want our docs to enjoy at work and feel good about what they're doing and be excellent at what they do. These 3 buckets present a nice framework that first you need to create a culture of wellness where it's okay to not always be okay, and we have resources for you to deal with that. The efficiency of practice is what gets the biggest bad rep, in that ever since we went on to electronic medical record, docs like to say, I'm miserable because of too many clicks. And there is actually some truth to that, but we really need to work on that as a separate issue to improve efficiency of practice. Hopefully with artificial intelligence, we can get better with that domain. And the personal resilience, that's what the lay people who don't know what we're doing in medicine say, well, you need to take care of yourself better. You need to sleep better, which is not untrue. And try some yoga. Again, as a practitioner of yoga, I find that very helpful to keep me grounded and mindful, but that's not the whole story. What we're going to focus on is really getting the system issues. You can see that the efficiency of practice is a big part, at least a third. I would argue it's even a larger piece of what we need to approach. But if we don't have a culture of wellness to start with, we're going to have a lot of casualties along the way. Why do we care? Well, this cartoon that came from another article in Mayo Clinic Procedures by Chanefeld, you'll hear his name often since he is really the person that's gotten this to an academic study and really given it credibility. He was at the Mayo Clinic when he started this work, and now is the chief medical officer or chief wellness officer at Stanford University. I've had the opportunity to hear him speak, and he's actually been gracious enough to lend me some of these slides. But I think we need to look at personal and professional repercussions of burnout. Okay, remember, burnout is an occupational syndrome. We define that elements. So if we look at the personal relationship, broken relationships can often happen as we disconnect if it overlaps into our personal life. Self-treatment with alcohol and substance is not uncommon among our perfectionistic culture. Burnout is not depression, but unchecked burnout can lead to depression and, in the worst case scenario, suicide. On the work side, the professional expectations, when I put on my hospital administrator hat, physician turnover is a big cost, and we'll talk about that later. Decreased productivity and professional effort when people are burned out. Their patient satisfaction is poor, they're reflected in their scores, but also in their patients' willingness to return for visit. And ultimately decreased quality of care and increased medical errors. Increased medical errors really impacts physicians. And you've probably heard of the phrase coined as the second victim. American Psychiatric Association lists these elements that was published by Hilo et al. And prominent is guilt and shame, feelings of inadequacy, difficulty concentrating, declining clinical judgment, avoidance of some procedures. This is beginning to sound familiar. Loss of confidence, trouble sleeping, difficulty enjoying leisure activities of daily life, depression, worry about my reputation, and PTSD. Second victims are healthcare providers who are involved in a traumatic event with a patient injury or an outcome, and they become victimized in the sense that the patient was harmed, and now they feel like they failed the patient, second guessing things. Dr. Albert Wu coined this term, but the quote is from Scott in a paper by Hilo and Moulton. Does this sound familiar? Let's go back to Dr. K. I just highlighted some of the elements that I thought yelled out at me. Guilt and shame, avoidance of some procedures, loss of confidence, worry about his reputation, and triggering if he does think about going back into the OR with that presentation. I'm not sure we put that in the narrative, but he shared that with me personally. So far, we've defined burnout. We recognize that it's largely a system problem, but providers are the target. Burnout is not depression, but they can coexist, and unchecked burnout can lead to depression. Physicians are human and have no immunity to mental illness. We need to reduce provider distress. So now what? Well, now I'd like to talk about what I really told you I was going to talk about, since we're now on the same page, and it's Akron Children's Hospital's journey. Our journey started in 2017 into 2018 when the Ohio Medical Association offered up free use of the AMA burnout assessment tool. They would help us administer it, they would score it, and they would report out the information. I engaged our CEO and board, and they supported offering the survey, but reassured me that all our docs are okay and they're so aligned and engaged, we're sure that there's not an issue at Akron Children's Hospital. So we administered this via email. I got some preliminary results before we saw the actual distribution of wellness or burnout. And we had engaged 64% of our faculty and med staff played and did the survey. The CPO said, see, I told you we don't have a problem. I thought differently because I can't get 64% of my med staff to show up in the doctor's lounge for a $100 gift card when we had a very good year and decided to distribute to all employees, including the docs. So I knew we were in trouble. I really fully anticipated that we would learn more challenges than we wanted to. And sure enough, 54% of my providers were burned out or at high risk for burnout. When I presented this to the CEO and the board chair, they immediately responded, well, when will you repeat the survey? I was a little cheeky and said, I'll look to repeat it when you give me resources to build some fundamental foundational resources so that we can try and get ahead of this. Just a little before this opportunity arose, then those of you who are involved in residency education or administration or residency directorship will know that the ACGME has focused on improving wellness opportunities for trainees for several years, and they've now started to put teeth into this. So an opportunity arose. My director of medical education, Dr. John Pope, approached me and said, "Hey, Rob, I've learned about this concept called opt-out counseling, and I'd like you to help me incorporate that into our resident orientation." I thought about this, and I had already started to do some research to present the total results to my board. And I said, let's take this as an opportunity to pause and expand this. If we need to do that for the trainees who, in my experience, the earlier people are in their medical experience, the less the stigma is imposed. They don't know what they don't know, and they are willing to seek some help. At least it seems like that in the last 3 years. So let's do it big bang. Well, we'll do it, but we'll do it for all medical staff. I'm going to move into some of the issues that I will capsulize the literature up until 2018 as the highlights that I reported to my board when I was trying to get more work done. The literature about burnout suggests that solutions need to be tailored for the local environment where the burnout exists. Resist one size fits all. While it is associated or can be associated with major depression, it's not the same. And conservative cost estimates say it's over $7,600 per doc per year. So in 2018, that was $4.6 billion per year for US healthcare. That's related to physician turnover, increased medical errors, increased ballooning medical malpractice. Some of the other literature interventions that look promising were self-care interventions. Some evidence-based, some people threw spaghetti at the wall and said, let's try it. Organizational interventions have included success with critical stress debriefing programs, peer-related programs, peer mentoring and peer support programs, and work re-engineering as the EMR is often implicated. My med staff wellness team engaged very quickly with me once I got these results. The president of the med staff then, Dr. Laura Pauloff, was amazing and still remains very, very engaged in the work that the med staff's done. And that's been years now. She's out of office, but stays the lead of that and has brought in the director of our APP services. And Jenny Michael, also is a big assistant here. They did a lot of work vetting evidence-based tools, such as My Wellbeing Index, which is a self-monitoring program many of you are familiar with. Sky Breathing is one of a yoga breathing program that has been proven to reduce stress and cortisol. And we've done a number of other interventions. But I wanted to start with the wellness bucket and create a resource for all when we tell them it's okay to not be okay all the time, but get help. So my partner in crime, Dr. Joe Varley, Chief of Psychiatry of SUMA, called that my BHAG, my big, hairy, audacious goal, and we're about to explore. So again, let's look at this diagram, and we're going to approach the culture of wellness. As Tate Shanafet tells us, distress is a multi-dimensional construct. So it includes burnout. It certainly includes depression or other mental health issues. Stress, work-life integration, professional satisfaction, and fatigue. Many other domains, but in the domains of distress have those some similar distinct drivers, but they have some shared distinct drivers, and they don't always move in the same area. So physician distress should be the target, not just burnout. I'm a long-term educator, and I really believe in adult learning theory, so please pardon me. I've done virtual presentations, but I've never done an asynchronous virtual presentation. So indulge this adult learner embracer by taking a moment. If you have a pencil or paper, just jot down 3 things that come to mind for why don't providers seek help. what would block you or a friend of yours that you think needs help? Okay. All right, now I'll share some of the literature that suggests what are the answers that they come up with. Ian Moffat wrote an article, "If you build it, they will come." And this is out of the Oregon University of Health Sciences. They were really the pioneers, at least what I could find, in terms of programs that really seem to be effective. They built it, though, within their medical school structure. Um, and the barriers included stigma, medical licensure fears, confidentiality, and time. That's really what came out of I's study. I would add, as I survey my own folks, it's traceable claims. They don't want electronic footprint. And as I implied before, it seems to be generational, whether you would accept an intervention or not. Uh, that is not hard science. That's really just anecdotes we've collected over the 3 years of us building our program. Another resource was in the Medscape survey that was over 9,000 plus docs. Over half said if I was having suicidal thoughts, I can deal with it without the help of a professional. And they didn't want to risk having to disclose to a medical board. I'm concerned about a colleague finding out, and I don't want it on my insurance record. So Dr. Varley conceived my project with me, and once he vetted me, we explored the literature and took off. Let me just tell you a little bit about my organization. Akron Children's is the only freestanding independent children's hospital on the whole eastern part of the state of Ohio. So our footprint is large. We go to communities when we're invited to they want to outsource pediatrics or they want more pediatric expertise. So we extend from Cleveland to West Virginia, north to south, from the outskirts of Ohio, right next to the Pennsylvania border, to the center of the state. So we've got a broad footprint, and that influences how we approach our venture. I cold called Dr. Varley when we decided we were going to run with this, and we brainstormed, and I'll share what we did from here. Once we started, we really wanted to get some expertise, and we actually visited, Dr. Varley visited Oregon University Health Sciences, and we're very grateful for their input. We also had another consultant who's in private practice in the South doing some of this physician wellness work to see what worked and what didn't work. And then we huddled with legal, with HR, and brainstormed and came up with a model that we're going to share now. The purpose was to provide barrier-free, non-emergency well-being outpatient counseling services. That's a mouthful. But basically provide access to psychologists and psychiatrists for residents, fellows, and all med staff members, not only from Akron Children's, but from the SUMA side. The concept did begin with a med ed pilot of opt-out counseling and evolved from there. I just highlighted the same slide and put the 501c3 in red so that we could take a little riff off of that and talk about the potential benefits of a 501c3 status. And I will get a little ahead of myself too as we talk about this. Basically as a 501c3, we have eligibility for public and private grants and donations, and we've gotten a lot of donations from grateful med users, medical doc users, from the med staff of both SUMA and Akron Children's, and from some public grant opportunities. We are a tax-exempt organization, and the status formalizes our structure and affords some limited liability. But I think more importantly, it helps our clients perceive APWI as a separate entity. And it's given us a little more independence as we expand. We're not as dependent to go through the boards of both parent organizations if we have some independent funding. Now, how do you do barrier-free engineering? we reviewed a few slides ago the different barriers. And let's just talk about the things that are in our control. Ultimately, we want to get ahead and make this normal to not always be normal. So the stigma, I don't know that that was a short-term outcome we were expecting, but confidentiality was certainly the main thing we wanted to work on. So some of the solutions we came up with is concierge scheduling by a psychologist. In the beginning, we had a single psychologist, doctor prepared. Now we have two, but we made sure that we deliberately did not have office staff. We have a physical office site, but it's off-site from both campuses. So it's accessible within 5 minutes of Akron Children's. And the office flow was designed so that there's no overlapping schedule, and basically no one waits in the weight room unless it's someone calling on the folks for an appointment unrelated to mental health services. And then we, fortunately, my psychiatry colleagues were reticent to use virtual. They like to have a visit in person. With our geographic footprint for Akron Children's, I didn't see that as a way to have an equitable service for all my med staff. So I pushed for it, and then COVID did the rest. So one silver lining of COVID. Time and convenience. Well, because we do it as a concierge service, it's flexible, personalized scheduling within 3 work days. Again, we haven't gotten to the point where we offer 7 days a week, but Mondays through Fridays. It's non-emergency hours. It is really for our opt-out counseling as well as the services that we want to give to folks. And then traceable claims. The solution we thought was brilliant and it worked. We give free care, so there's no bills dropped. We use a paper record that we keep on file in locked drawers in our office, so there's no EMR. However, once we wrote our first prescription for an antidepressant and someone took it to a big pharma chain, all of a sudden that showed up in their EMR because of the way the big pharma chains are so linked to the hospital's EMRs. So we haven't been able to divert that, but we do warn people if they're being prescribed medicines that this may be a conversation they want to have with their primary care doc. Opt-out counseling. I've used that term a lot. I imagine you all have some preconceived notion, but this is how we translated opt-out counseling. We had individual pre-scheduled introductory sessions with the clinical duties of the trainees covered. So it's built into their schedule. It's normal for a doc to go to opt-out counseling early in their career at Akron Children's. Trainees may opt out, hence it's called opt-out counseling. Just like in any other forced function, you want to make the right thing the easiest thing to do. So if it's already scheduled and I forgot to opt out, I might as well go see what this is about. But if they do opt out, they resume their regular schedule. And unfortunately, the first year we ran a pilot of just the Akron Children's residents, and a third opted out. And in discussion with them, they didn't want to be seen as a wimp, because even though the time was already programmed, some of those who were in most need of the service were too proud to opt in. Within that first year, so we did a pilot in the beginning, and then when we went big bang with our whole service, after 1 year, faculty learned of the opt-out issues and said, we want this for our new faculty. We want this for all people that enter our system. So we built that in, and that was able to go forward until the last 6 months where our volumes were too high for our current staffing, and we had to put a temporary reprieve on opt-out introductions. However, there's good news I'll tell you about in a minute. All right, so you want to build something like this. How wacky is this? Dr. McGregor is telling us this is doable, and it is doable. You just have to imagine and get engagement. I approached my board and my CEOs and said, here's an opportunity for us to move this. We're building this initiative. We want it to be sustainable. We need you to ante up 300 grand each for us to finish the build of Akron Physician and Wellness Initiative, get our not-profit status established, and then we will contract as an APWI, we will contract for services from the two parent organizations. So all the administrative things, APWI buys the time of the individuals at fair market value for Akron Children's. All the professional features, both the medical director, the peer review, and the providers, are purchased services from the Summa Health Medical Group. So that is the concept. I'm sure you'd have lots of questions if we were in person. Originally, Dr. Varley and I thought that we made a single one-time ask and really thought that this was going to cost us about 300 grand a year. So we would have about 2 years to be completely self-sufficient. Fortunately, we were wrong, and the health systems just assumed they would pick up our initial cost of doing business, and have done so graciously for the first 2 years. Basically, it cost us about 325 grand a year before we've made increases recently with a number of partial part of a psychiatrist that we buy, and are adding a third psychologist. Because we've steward our money pretty effectively, we do have reserves and interest that we've been able, with donations, we've been able to subsidize the cost of a third psychologist without having to go back to mom and dad, so to speak. Our governance is independent of the hospitals, so to speak. The two member organizations, they assign the first 3 board members from each hospital. So Dr. Varley and I were not only board members, but I was the inaugural chair, and he is currently serving as chair. And we soon hope to add 1 or 2 community board members, because our goal is to really enhance our philanthropic reach and expand services through the philanthropy. The terms of the office is 2 years each, and then can repeat. The treasurer and the secretary are non-voting officers of the board. I've already alluded to the operations, but I'll spell it out so you have a slide to look at. APWI contracts with Akron Children to provide administrative services to APWI at fair market value: accounting, finance, philanthropic oversight, and legal. APWI contracts with the Summa Medical Group to purchase 2, soon to be 3 psychologists, and initially no psychiatrists, but in week 1 we realized we had to have a psychiatrist because people had medications they needed to refill. And that's grown from 0.1 to now currently 0.5 FTE. Our medical director is Dr. Varley, and peer review is done through the Summa Medical Group. Both members then buy services for mental health for their respective trainees and med staff. So that's the rationale that they continue to cover our original revenue. So I would venture to guess they get a pretty good deal for their dollars to provide this kind of service. So we are 3 years old, and full transparency, this is my grandson Caleb, and he did just turn 3 about the same time that we turned 3. So how are we doing? Well, this is actually 37 months of utilization, because when I first put this in, we had a placeholder at 36 months, but we've added 6 new clients. So this is a little over 3 years in business. 415 providers have completed the intake, independent of the opt-out counseling. So this is people who reached out and went through the system. We had 6 new clients in March. 218 clients are currently in active treatment. On average, most people need about 5 sessions to move on, but we have some that have required more than that. They have the option to see a psychiatrist only or a psychologist and a psychiatrist augmenting. All will see a psychologist for entry into the program. So far, 38 different specialties have been represented seeking services, and 43% are televisits. The clients are basically trainees, more than half, and med staff. This is coming up, and actually from old literature, that's pretty significant that 48% of these providers are either advanced practice providers or staff physicians. By organization, Akron Children's, we got a head start. We've had 137 people get help. Suma's only had 132. At our last tally, 50-50. We do a paper survey after people have their first encounter to say, what are the benefits of seeking treatment at APWI? And it's interesting, early on, it was the things that were the barriers, that no insurance, no health record, no EMR, no cost, ease of scheduling. But now it's very clear to all of our folks that these providers, these 3 psychologists, all they do is deal with provider mental health. And that rises to the top now. Ease of scheduling is still pretty high up there. So as far as convenience, even though we're Monday through Friday, it's been pretty well sought out. One thing I'd like to highlight, though, is without APWI, they would not have sought treatment. 46%, almost 47%, would have suffered in silence, like Dr. K. We keep pretty arm's length from the providers that receive care, but I do know that there have been at least 2 that, even though this is not emergency services, entered through APWI because of the stigma-free perspective, but were found to be acutely suicidal and escalated to inpatient therapy. So when people ask, what's the cost return of this investment, even regardless of the issues with physician turnover, preventing 2 suicides, I don't know how to put a price tag on that. Referral sources have also evolved. Early on in our experience, it was opt-out or orientation, or someone from leadership said, why don't you look at this? Now, I'm pleased to see that it's colleagues. So if colleagues think it's great and they openly discuss using it, I think we're also getting at the stigma. I can't prove that, but I think it's working. We've had almost linear growth since we opened the door with a soft start in February of 2021. And there were people knew this was coming, so we had pent up demand. So we started off out of the gates very, very busy for that, first thing, but our incremental growth has continued. So we opened February 2021. Immediately by March, we had to add a psychiatrist because we had prescriptions and we had needs that were better suited for a psychiatrist. In November 2021, we added a second psychologist, knowing that we were about to go live. So the first, up until 12/22/21, we were just giving services to Akron Children's. And then in January, we opened to the Suma Health Medical Group. We've continued to have growth, as you can see, and finally we got to the point where we had to increase our psychiatrist time because of need, and we have a 3rd full-time psychologist joining us this summer. This is our team. Dr. Christina Rowan is right front and center, and she is the lead person and has really kind of been the pioneer. Dr. Miller is to her left, and Dr. Demetrius Tissaris is the psychiatrist who loves working with us enough that he would like to come 100% on board with us. So this is a brochure that we distribute, leave around in the physician's lounge. We put it on our webpage. No cost, no insurance, no electronic medical record, no referral, no barriers. So why would we use it? This is a way that people can scan in to get an appointment. But for you, I would encourage you to go to visit our website to get more information. And if you have questions, since this is asynchronous, feel free to email me at rmcgregor@akronchildrens.org. Oh, what about Dr. K? Dr. K reported to me, and this is a quote, "I find myself in my first ever counseling session at APWI. By my second session, I recognized that I needed to slow down my rash thought processes and reconsider my fear-based avoidant decisions. With time, I began to recognize the value I bring to my patients by continuing to operate like I did before my tailspin, mainly with my primary new work to change my self-imposed perfectionism. I can really give value. Through my ongoing sessions, I reflected that my appreciation of patient interactions had really been regressing over the last several years. And now I'm happy to report that I'm much closer to the enthusiastic, hopeful doctor that I was when I began to practice. And I look forward to each clinical and surgical session. I feel like my patients benefit more from me now than they ever have. Had this resource not been easily available, I fear I would have left practice and regretted it forever." So the final challenge, we need to normalize mental health care and medical education and practice. We need to replace intolerance with acceptance, perfection with vulnerability, judgment with grace, and hiding with sharing. In essence, we need to make it okay to not always be okay, but get help. There's some selected references, and as I said, I'm more than happy to field your questions via email. Thank you for your attention.